payment and resources and that. So, I mean, I think if everybody would be happy that we could write to the Minister just to say that we met, visited the site. We thought it was very useful, the service they're provision, and to ask for an update on the business case.
Yep.
Okay. We also got our flu jabs, which again was useful for ourselves with regard to protecting ourselves, but more importantly, it created a wee bit of media focus. So obviously we want to use our positions to get the message out there that the flu vaccination protects the individual, protects their families, people they come into contact with, but also protects the health service, particularly with regard to reducing winter pressures. You know, we will have people ending up at our emergency departments over the next few months with unfortunately bad flus, but the more people who get vaccinated, hopefully that can be reduced and, as I say, decrease the pressure on our healthcare. Today, then, we've had a busy couple of days as a committee. So today we met with businesses from Enniskillen area and also council reps from both councils within the Western Trust area. Just we had a really good conversation with them over breakfast this morning, and I'm sure members, including myself, will use that conversation when we're asking questions of both SOAS and also the Trust. And then after that we went to the Cancer Focus Centre here in Enniskillen. So I don't think anybody that was there could not have been impressed by the facilities, the modern building, but more particularly the service that Cancer Focus are offering through their staff and their volunteers, counselling services, other very important services for individuals who have cancer and their families. And I, again, just in relation to that visit, I would ask if members would be content that we write to the Minister just to say again that we visited this facility, very impressed with it and the work that they're doing. We're aware of a couple of business cases and to develop that within hospitals across the north, and that we would ask for an update in relation to that. Everybody content? Okay. And then obviously we're in the South West Acute Hospital, and we're delighted to be here for this meeting, and we have had a tour of the facilities. I have to say, from a personal perspective, this is my first visit here. I couldn't not be impressed by the modern facilities within this hospital. It's a huge facility, and I want to thank the staff of the Western Trust for the tour and for accommodating the committee meeting this afternoon. Okay, so that's enough of that. Moving on then, draft minutes. Can I refer everybody to the draft minutes of the meeting held on the 20th? Are everybody content with them?
Content.
Thank you. Any matters arising? None? Okay, so we're moving directly then onto the main items of business. So item number 5, oral briefing from Our Acute Services. Can I refer members to papers at tab 5, page 13 of the main pack? And then, welcome. So can I just welcome Helen Hamill and Jimmy Hamill and Karen Eccles, all from Save Our Acute Services.
Thank you, folks.
Thank you. No, put that in my bag. Jimmy.
So you're all very welcome. Thank you very much for attending. We obviously received a written briefing from yourselves, so I'm going to hand over to yourself just for some introductory remarks, and then we will take questions from members here and online. And just if I could ask everybody, because of the nature of where we're at, if you could speak as close to the mics as possible. The meeting will be recorded and online. It's important that we're able to pick up everything that's said. So over to yourselves.
First of all, Chair, members of the committee, thank you for the opportunity to speak today. We represent Save Our Acute Services, a campaign formed in response to the suspension of emergency general surgery at South West Acute Hospital in 2022. 3 years on, over 83,000 people in Fermanagh and West Tyrone remain an average of 2 hours away from life-saving care. This is not sustainable, it is dangerous. Winter is here, and already we know that Athnagelvin isn't coping. How could it be? With corridor care running rampant and cancer patients being left on the floor. We know the evidence. Requia told this committee that people are coming to harm as a result of time spent in ED departments and waiting to be offloaded by ambulance crews. NIAS has confirmed delays are leading to increased deaths. The Royal College of Emergency Medicine data shows that one excess death for every 72 patients who wait 8 to 12 hours in ED. SOAS is very, very positive about the future for SWA. We published our roadmap for SWA in January. Its 20 recommendations are a step-by-step guide as to how we can resolve the issues around timely access to emergency surgery for our local community, while at the same time significantly contributing to the fight to reduce waiting lists across Northern Ireland. We like the idea of solving a problem and availing of an opportunity at the same time. The roadmap has received support from right across our community. We need the support of you, our politicians, and the various health bodies across Northern Ireland. We cannot do this alone. This is a David versus Goliath situation. The Trust will present you improved mortality rates, called RAMI, Risk Adjusted Mortality Index. We have commissioned an independent statistician to review the RAMI data. As you know, when it comes to data and statistics, it's about what you put in and what you count. It seems clear to us that the sample size is far too small for any health officials to use RAMI in this way as a basis for sweeping hospital changes. As you know, patient and staff experiences, the people behind the numbers, are what we are here to talk about. That's what concerns and motivates us. The messages we want you to remember is it's not about if people live or die. It is also about how they experience health, the waits, the traumatic journeys, it's the uncertainty. It's about long-term harm. It's about delays in EDs, delays in ambulance transfers, and how people recover. The RAMI data that the Trust uses is not an appropriate benchmark when used in this way. CHKS, the company that produces the data, says you need 1,000 deaths. There are only 100 deaths from surgery across the Trust each year. It is not statistically significant. No claims regarding improved outcomes should be made based on that data. But let's not get lost in the weeds of the data here. The numbers we want you to think about are the 93 kilometres between Fermanagh and Athnagelvin, the 10,000 people who have been sent up the road to Athnagelvin, the 45-minute major trauma target that cannot be met, the 2 hours on average that it takes to get from Fermanagh to Athnagelvin, the 300,000 people from Loughearn to Lough who are suffering the unintended consequences of the decision-making by the Western Trust, and the 77,000 people from this area who have submitted consultation responses during the past 3 years. The Trust will talk about the difference between patient experience and patient outcomes. They will say that patient outcomes are measured by RAMI and other clinical data, and they will play down the importance of patient experience. So we need to tell you today that patient experience proves to us, and hopefully to you, that actual patient outcomes are very significantly and seriously adversely affected in ways that are not picked up by the clinical data the Trust will give you. Mark McGuigan was 61 years old when, on the 1st of March this year, he developed gallstone problems at home at Rosslea. As he was over 55 years old, the surgical pathway put in place by the Western Trust meant his ambulance bypassed SWA. It went straight to Altnagelvin ED, where he sat for 3 days, developed sepsis, developed pancreatitis, and eventually developed necrotizing fasciitis. Mark died on the 17th of November, the 3rd year anniversary for when the Western Trust stated that the surgical services were being stood down at SWA. Mark was a friend of this campaign, attended many of our meetings, but he's much more than just a statistic. He is a sign of how dangerous these pathways are to the health of our population. Mark's story will not be reflected in any RAMI stats, as he never actually made it to surgery. He still had his gallstones when he died. The committee will be aware from the recent developmental update that there is still significant work to be done on the implementation of the 10 strong recommendations from the RECWA review. Our QIA themselves recognised in a recent meeting with the Health Committee that on the basis of the information they have, that the 2 urgent recommendations have not been met. They indicated that they continue to be very concerned with this. The regulator stated in the report, if these issues persist, it will undoubtedly adversely affect the effectiveness of the clinical pathways and patient experience. SOAS has concerns as to the extent that these recommendations have been implemented so far, and to the extent to which they're capable of actually being fully implemented in the future. Our message is clear. Rural communities deserve equity in healthcare. We need a funded plan to restore emergency surgery at SWA, commission its spare capacity, and create an integrated surgical network. We're asking you, our MLAs, to please press the Health Minister for a clear timeline for reinstating emergency surgery, to consider a call for an independent analysis to assess the impact of the suspension of surgery on the population of the South West region, to support a dedicated rural workforce planning initiative to address systemic issues, to ensure rural health equity is at the heart of your scrutiny work, and finally, to support the case for change. Make SWA a rural area hospital that can benefit the entire Trust region and beyond. This is not just about Fermanagh, it's about the entire Western Trust. It's about fairness, safety, and the integrity of our health system. We cannot allow reform to happen through collapse. We need leadership, we need action, and we need it now. Thank you.
Okay. Thank you very much. It was useful. So I'm just going to go straight on to questions. I mean, we have had the Trust here before. What will be important, certainly for me, but I expect for other MLAs, is patient outcomes. So, I mean, you have stated in your written paper and also today that in terms of the figures that the trust are using, you don't have faith. Could you just explain exactly why that is? I mean, because these are independent figures.
Yeah. Thank you, Philip, Chairman, and thank you again for asking Save Our Acute Services here today. We do challenge the Western Trust claim of improved patient outcomes following the suspension of surgery. At the Assembly Health Committee in March, the Western Trust stated, effectively the RAMI scores for Altnagelvin have continued to fall to the extent that if you extrapolate the data to look at the mortality rates, you find that due to the change that we have made, every 40 days, one patient survives who would not have survived. The Public Health Agency reviewed the RAMI data. We made a number of Freedom of Information requests, and they cautioned the Western Trust about using these figures at all. That was a concern to us. We started to take a look at the information. It was clear from CHKS is the company that produces the RAMI data. They're an independent company. That is true. They're very, very clear, though. They say that indicators that count events such as death suffer from great uncertainty. To be confident of a rate to within 10 percentage points, approximately 1,000 deaths must be included in the data set. That's pretty unequivocal. The deaths during surgery across the Western Trust average at about 100 deaths per year. Okay, this is very significantly short of the 1,000 deaths recommended by CHKS. So based on that information, we commissioned an independent statistician with no connection to Northern Ireland, a fellow of the Royal College of Statisticians who has more than 500 published articles. He worked along with surgical and medical consultants from this area and they analysed the information, and they advised us then that the Western Trust claim of improved outcomes is without statistical basis. That's a bit of a mathematical phrase nearly, okay, but when we asked how can we phrase that in a way that's more understandable, we were told that we could have said that the claims of improvements in patient outcomes based on RAMI cannot be substantiated, and that was pretty unequivocal. The correct analysis has not been done. It's significant to us that the medical director, the chairman and the chief executive of the Western Trust continue to repeatedly state this claim of improved patient outcomes. And that's, look, it's very difficult for our community to hear these repeated claims. We always find them difficult to understand and to accept. We have been in contact with more than 500 direct families and patients. And both us and these families in particular, they're in no doubt that patient outcomes are significantly affected. This is not just about patient experience, but the actual outcomes, okay? I only have to talk about Mark, okay, who's a very good example, okay? It was very difficult for our community to hear the phrase, and it's during this time, this was in July when the attempt to launch the permanent consultation started. During this time, there was no evidence of any individual patient harm for a single patient. And so it's very upsetting, and I'm trying to be careful in the language that I use to our entire community to constantly hear that actually there's been improved surgical outcomes for patients since the suspension of surgery. We do have an ask. We asked that the Health Committee, okay, call for a correct and comprehensive independent analysis to be done to define precisely the impact that the removal of emergency general surgery has had on the specific patient cohort from Fermanagh and South Tyrone, okay, and to identify that cohort appropriately. And we do ask that. We do intend to contact RQIA as well to update them with our response. We think that the PHE and the PCC may also be interested in that information, but that's the basis on which we challenge the data.
Just so I'm clear, I mean, and the trust there will obviously, I mean, we will raise this with them, they're on after you. So it's important. So what you're saying is, you know, the data set is so too small to be able to make any judgment. So you're not saying you have any data to suggest outcomes are worse or better, but from a community perspective, you find it hard to believe that what you're being told. But is that a fair assessment?
I think the fair assessment, and this is why we were very, very clear with the statistician to give the language that is appropriate, okay? That the claim of improved outcomes is without statistical basis, okay? The RAMI analysis data should not be used for such a small data set. So what we have to do is ignore the data. Our experience of talking to over 500 patients and their families is that there are significant, there's rather than an improvement in patient outcomes, we would say from our significant conversations that patient outcomes have disimproved for the patient cohort coming up specifically from the SWAT catchment area up to Atnagalva. We can't prove that yet, and that's why we're asking, and it's an ask of the committee that perhaps, like, we brought in an independent statistician, okay, and we're very, very happy to take his information. But we think that for a totally independent view, it would be good if the Assembly Health Committee could take a look at that data. It's a key piece of data for our community, okay? And I can't explain enough the upset that it causes. I could use stronger words than upset, okay? But to individual families who have suffered significant outcomes.
Okay. Just moving on to something totally different then, because, I mean, it's certainly my view, I mean, we're going through a reset, and there's hospital reconfiguration plans out there and consultations, and there's various different aspects of our health service being consulted on. It's my firm view that any change, any change should be planned, and it should be done in co-design with the medical profession, but also the community in which it's involved. You're saying there was 77,000 consultation responses in relation to this specific issue of emergency general surgery withdrawal. So, I mean, anything I'm raising with you, I will raise with the trust, and I don't think they'll be surprised. I mean, I was at a meeting in Enniskillen last night with engagement this morning with businesses and council representatives, and that there is a sense of perhaps a lack of proper engagement between the trust leadership and the community. I mean, how do you think that can be solved so that, I mean, I did say this is a wonderful facility. I want to see this hospital doing the maximum amount of medical procedures that it can do. I mean, I think that should be co-designed with the local community. So in terms of engagement between the likes of yourselves and the trust and the community and the trust, what would you like to see happening?
We think engagement is very important. Okay. I think the first thing to say is that this whole issue of emergency surgery being suspended, it's a hugely upsetting and emotive issue for our entire community. Okay, we do our level best to reflect the concerns and the stories of patient staffs and their families. As far as the present relationship with the Western Trust from SOAS is concerned, we'd have to say that it's mainly through email, social media at the moment, but that there is no trust between us at the moment, and that's an unfortunate state of affairs. We did meet with the Trust. We had an engagement meeting on the 10th of March with the Department of Health, and the Trust Chief Executive and the Medical Director were there. We did identify a number of areas of common interest. It was said that the Trust needed additional resources to boost theatre uncommissioned spaces, which is very significant to our campaign. But as far as currently talking to the Trust is concerned, we know that they've proposed what they call a broader people and place-based visioning programme covering all health and social care matters across Fermanagh and South Tyrone. Now, that's a very broad piece of work that aligns with the Minister's neighbourhood model of care framework. The chairman has told us it's going to take 5 to 10 years to implement that. Okay, now that's a very significant length of time, and that doesn't ally with what we talk about mainly to the trust, which is about that urgency around getting emergency surgery back. The Minister, when he intervened, and we certainly appreciate his intervention in July in the public consultation, he asked that the Western Trust act quickly to restore confidence and develop a vision plan for SWA, specifically. Now, we are happy to talk to the Trust with regard to that, acting quickly to develop a vision plan for SWA, because that aligns with our objectives. Okay, the Trust determination to speak about their long-term 5 to 10 year plan doesn't align with the urgency that we need to see treated with something. But we are happy to talk to the Trust with regard to the vision plan, and it's very important. One shouldn't stop the other happening, but SOAS don't have to be involved in both. We think it's very important for both to happen.
And just the last question for me. So when we arrived today, we couldn't get a car park space. So I mean, there's an awful lot of things happening. There are lots of people working in this hospital, and there's obviously a lot of procedures and people attending this hospital. So, I mean, how do you think you're navigating? Because I mean, there's always a danger in a campaign like this when you're continually talking about the negatives, that you're actually fulfilling.
Okay.
It's a self-fulfilling prophecy in terms of talking down the hospital. When I know that's not what you want to do. So I mean, I'm just wondering what's your view on that, and how the people of Fermanagh can promote the good things that are happening in this hospital alongside, obviously, the demand for additional services.
I think, Keith, SWA is significantly, I'd go further, seriously underutilised. A lot of the cars that you'll have seen today are staff. We do know across Northern Ireland that Daisy Hill, the Mater and SWA are the three main sites which are said to have done 18,277 procedures, but there's no breakdown on those. So we have no idea. We would assume that the Mater does the bulk of the work. The Department of Health do say that SWA as an elective centre can perform elective general surgery, gynaecology, breast surgery, paediatric surgery and paediatric dental procedures, but they are by consultants visiting the hospital. We don't have any consultant surgical workforce here for an emergency should it happen. We have had weeks where our elective centre in an entire week has done 18 cases. And these are since the summer of 2025, any of these figures. And our DPU had 5 cases in a week. We've had a week where there were 13 cases in the elective centre and 3 in the DPU. The hospital has not been utilised at all appropriately, and it is such an asset screaming out to be used. I mean, I know that you've been in other hospitals before. This is a unilateral build. It's got everything in it except the determination to make it thrive. We also have to live with a narrative which said that recruitment to this trust was impossible in this area, but there has been no attempt to recruit significantly to this area in any permanent consultant jobs since May 2021, to our knowledge, and that was the last time we were given FOI evidence on it. But I do know that UTV recently looked at the recruitment issue, and predominantly people were looking for locums, short-term jobs, part-time, as and when, and elective surgery. But one of the issues that we feel makes us unsafe is also the fact, I think you were in the elective hub today, I saw it on social media when we came out, but Requia, as part of their 10 recommendations, said that there had to be direct access to a consultant surgeon, not periodically or not whatever day they're there, but there had to be direct access. There isn't, there's phone access. And the Royal College of Surgeons wrote a consultation response when the Trust went out to temporary consultation, and they actually used this phrase in it. They said it's inconceivable that a patient presenting in such a state to SWA, it was referring to trauma, but patients in such a state to SWA would not be seen by an elective surgeon team who is on site and stabilised prior to transfer. But they're not on site. So therefore, our population and our staff are aware of the disadvantages, the overwhelmed ED, and I don't know if it was overwhelmed when you were there, but it's overwhelmed every time I've been there recently. But I do think we represent the staff, and I think the negative narrative is something that has happened through poor management of consultation periods, through lack of recruitment, through those types of short-term job adverts. There's people constantly coming to us talking about not able to get full-time contracts, that they can't get employment, that you can't set down roots if you're given a year of a job. But there are jobs. However, they're being placed at Galvin, and at the moment, SWA was funded when it's fully funded. It was funded for 6.5 full-time equivalent surgeons. Galvin had 8.5. There are currently 20 surgeons in Galvin and none in SWA. Now that's based, I'm not a doctor, but I do have common sense. That's not fair. It's just not fair. We also, I think, rather than sort of saying we're giving out a negative narrative, we make the staff feel so content to talk to us and so safe. We've never made a staff member identifiable, that they do come to us and they talk about things like in the A&E department, and I'll just choose randoms, but these are from staff members, so therefore the negative thought processes don't prevent the staff from coming to us. Yeah. They're coming to us at great speed. There was a patient recently who had an abdominal rupture and has been assessed by a specialist in ED here. The specialist was on a phone in Galvin. That patient could not get transferred to Galvin by an IS ambulance to go to theatre because there was no bed available in Galvin, and until that bed is available, that patient can't move. And I think I kind of opened a can of worms that I need to mention. There has been, since Encompass went live in this trust, which was the 8th of May, I think. I'm sure the team will correct me if I'm wrong, but it's on the 8th of May, Encompass should have identified the time for a patient from they arrive at triage in SWA to potentially where they end up needing surgery and going to Galvin. There have been 3 memos in the ambulance service in that time warning not to sign on patients in the second ED, but to make it known that you're there to 2 different members of staff in Galvin. So there is a rule at the moment where NIAS are not transferring patients until there is a bed available, and those are like hen's teeth. Galvin is overwhelmed before we go up there. This is a paramedic speaking. NIAS had the capacity and resources to respond to calls in the community, given the local landscape of the health service prior to the suspension of EGS. Since its suspension, more ambulances are having to travel more miles with sick patients to wait at the back of a queue in Galvin. So from the nursing point of view, there are patients constantly queued up. One example, there was a man who waited 77 hours. He went in with a significantly bad foot situation. I don't know if it's post-surgery, but as he remained in the department for those 77 hours, the foot became less and less viable. That man had more significant problems, but the orthopaedic consultant had to bypass him twice because there were people already in a queue in Galvin. So therefore, we're always going to be back of the queue here, metaphorically and physically. It's just a fact.
Okay, thank you very much.
Thank you. Sorry, big long answer. Sorry.
I'm just going to allow other members on here. Call.
Thank you very much, Chair. And look, This is certainly not meant, by the way, initially in a condescending manner, but can I thank you for the work that you're doing, because I did a bit of studying of community development and community activism, and I think what you have done is, for by the issue and the people in the room and what we're doing, I think actually the model that you've taken, where you engage with people, you interrogate the issue, and you try to shake the power that is there for decisions. I think that is actually admirable. I think you're one of the better examples that there has been ever in terms of doing that. And one of the things is that quite often as politicians we get people come to us and they complain about something, and we get frustrated too whenever we hear what it is that they're complaining about, and it's almost like we have to say, but what do you want instead? Like, what have you got, what's your alternative? Because otherwise we're just going to go and complain about nothing. And then we have this.
Yep.
So can you talk us through the development of this, maybe give us some of the highlights of it, and maybe where you feel some of the issues of this could really could stand good stead in terms of being able to be offered as an alternative?
Okay. Do you want to start, Karen, and just do the local? You sure? Okay. Helen had a line, actually, during the introduction when she said, we like the idea of solving a problem, okay, and availing of an opportunity at the same time, okay? And that notion that, to our mind, we do have a problem, okay, with regard to the lack of emergency surgery here. But there's a genuine opportunity in this hospital. You have travelled around the hospital today, okay, so you've seen the astonishing build that it is, okay? I don't know if you've seen the uncommissioned rooms and the uncommissioned theatres, but apart from the fact that it's an astonishing build, there's all that available capacity there. So what we did as part of the roadmap, which we launched in January, is that we actually went back to the original business case for when this hospital was built first, and it was really important, okay, because that gave us figures that we could see what the plan was for here. The hospital's running at about half the level of activity that was in the original business case. So that should really tell us something. That this idea of having physical hospital infrastructure available in the region, in particular to help to drive down waiting lists, should be something that's very attractive to everyone across health, and certainly the health committee, okay? And it's very important to us. This is a really positive document, okay? We think it's very well researched. It's been out since January. We haven't been challenged significantly on any of the facts in it. But the key is that it says, how can we solve the problem of getting emergency surgery and build on the opportunity of the capacity that's in the hospital? And I have to say the incredible staff that are in here as well. Okay, so it looks at an accelerated elective care work coming into the hospital, okay, across a number of key specialities that can be identified. Okay, that bringing a level of surgical activity into the hospital. Okay, complemented by cross-border surgical, elective and emergency activity that will serve to make the hospital much more attractive for consultant surgeons to come to be based in. Okay, and that is the core of the roadmap, but it's a very positive roadmap, and it sees a really bright future for SWA, which we think is very important.
And have you had an opportunity to discuss this with the Trust, or to be able to maybe even with the department in terms of some of the wider departmental responsibilities or responses that would need to be to it?
Yeah. We met with the department on the 10th of March and we formally presented the roadmap to them, and Neil and Brendan Lavery were at the meeting as well. Okay, and I have to say it was a very useful meeting. There was a lot of common areas of interest identified. Okay, and there is an acknowledgement, certainly with regard to the elective area, that there's lots of opportunities here. I think the part of the argument that we want to make as a campaign is that we need to look at the emergency surgery as well. That's that local element, is us getting the emergency surgery.
Just secondly then, when I woke up this morning, I was thinking about being grumpy. And the reason I was thinking about grumpy was I thought to myself, I'm going to have to drive home later and it's going to take me 2.5 hours. And I thought to myself, that's a bit rich, because I remember proposing that we actually come here today, and I thought, well, there's not much point in being grumpy about it at this stage. But then whenever actually it sunk in a wee bit more, I was thinking about Mark McGuigan, and I was wondering, we do hear a lot about time scales, and we hear about being able to be, there's time to get here, then there's been treated here, or there's time to bypass here. Can you just give us maybe a wee bit more detail about those timings? Because I will probably be home quicker than if you were going from Garrison up to Gelvin, and I will probably be right across to the east coast of County Down in that time. So maybe just to give us a little bit of a sense about the timings.
Thank you for that, that question, Alan. I suppose the central tenet for us to take this forward through the elective process, etc., has to be the restoration of emergency surgery. And we have two key areas. We have emergency surgery and we have trauma care. Geographically, our demographic determinants put that as a massive challenge for us as a community, a rural community. What happens is, and what is set out, and maybe to put it in context, some of the documentation and the process that we use to deliver services is utilising information and process that's used in Britain that has a different demographic. And in relation to that, distance from hospital, from home to hospital in the UK, 95% of the population in the UK are within 12 miles of an emergency department. And that's broken down further and averaged out, most people are within 4.7 miles in urban areas of their hospitals, and the maximum distances is about 10.9 miles for the rural population. Now that's exceptionally significant for us for a variety of reasons. What has happened with the removal of emergency general surgery, it has compromised the integrity of our major trauma network. Our major trauma network is the centre is Royal Victorian Hospital, but it is supported by 8 regional area hospitals that can stabilise patients and then transfer patients in a more stable condition to the Royal. A quarter of those have been removed as a result of emergency general surgery closures in hospitals. Why is that important? It's really important. It's a significant statistic. If you encounter a major trauma episode, if you can get to a major trauma centre within 45 minutes, your survival rates increase by 20 to 25%. That's a very significant improvement in a health outcome. In relation to surgery, emergency surgery, the recommendations are 60 minutes. But what is often missed as part of this conversation that we have with people is that when the South West Acute Hospital was first developed, there were challenges, absolutely, and rightly so, as to the location and how it would serve the population. But what happened was it went to judicial review ultimately in 2004, and that's where it was established that it was necessary to have the hospital here in order to comply with those recommendations. The fact that we don't make those, we are now seriously challenged. We talk about standards in care. We cannot meet those standards, or we will never meet those standards with the removal of emergency general surgery to what would be considered surgical and major trauma international guidelines. If we're looking at our evidence base, that's what it states. These are international guidelines, accepted practice. In addition to that, we really don't understand, since the removal of emergency surgery, there's a process in emergency care which identifies and records situations that happen and the care patients receive through their patient care journey. It's called TARN. That, unfortunately, became defunct in last year, or July, a couple of years ago, in relation to a cyber breakdown. However, they have reinstituted that and they've got it up and running again. But we can't see any data in relation to that being done here. We don't see any of the data. The last recorded data in relation to this service was, that I have seen, is 2018, 2019. So we're blindly going to go into a reconfiguration of networks of hospitals where we have no data on the emergency cover for a rural population in Fermanagh that can impact 80,000 people. So the travel times are very relevant, and I think when we put it in context and we look at what service provision is given in Britain and what's acknowledged as best practice, I would have to travel 60 miles for access to emergency care. So I think that's clearly outlines, hopefully, Colin, your question, and makes it clear.
Can I just give one tiny clarification, or maybe two actually? The trauma data here has only been collected in the last 2.5 years manually, one man in each hospital, but there has been no data compiled for analysis, no interrogation, so therefore there would be no way to tell if, for the sake of argument, playing devil's advocate, maybe things are brilliant here, maybe trauma outcomes are 10 times better than they were when we had surgeons in our hospital. I don't think they would be, but it's not okay to reconfigure services without checking out the exact level of damage or improvement in all cases in the region. There is no data being collated at the minute. And just before you get grumpy, from Rosslea to Altnagelvin, where Mark lived, takes longer than if you went to Belfast and you went to the new bus station and you said, I'm going to Beaumont Hospital in Dublin.
And Colin thankfully woke up happy this morning, because he normally wakes up grumpy. But I get shouted at the last meeting for allowing things to go on too long. So I do want to keep check in today's meeting. So I'm going to, now selfishly that I give myself enough time, I'm going to ask all members to be concise, and if we can be concise moving forward. You're happy, Colin?
Yes.
Okay. Yourself?
Yep. Thank you very much, Mr. Chairman. Look, I really welcome the opportunity today to come and see the facilities here at the SWA. It's my first visit, and I have to say I'm hugely surprised. And I think you have to actually see it to appreciate the size of the site and the opportunities that are there to be grasped. But a building like this, with all its modern theatres and the ensuite patient facilities, it should be playing really a major role, not just locally here, but regionally. So I'm glad that some of the unused theatre capacity has come online recently. But what are the other opportunities do you feel that SWA has that still need to be tapped into?
I think, Alan, some of the opportunities that have been missed here, SWA should be a centre of excellence. SWA should always have had the available resources and savvy to just decide. We retained stroke services here because they were batting way above their standard. We had standards which were among the top in the UK. We had initiatives such as Our Hearts, Our Minds, which was a preventative heart programme, which was unique to this hospital. These are all in the last 10 years. If we had embraced those and built around them more and capitalised on them, again, I feel we would have recruited, we'd have gained much more attention. We also have missed out, in my opinion, we've missed out on cross-border funds when Northern Ireland has none, whether it's CAUT or SEUPB, because one of the most successful things that those European funds have provided are the North West Cancer Centre in Altnagelvin area, and the paediatric cardiology, which obviously takes us way down from wherever to Dublin. And we're living here in an area where we easily should be providing something there. And I know that the Chief Executive is here, and I'm sure he can say more than I can on CAUT, but I did read at one stage where he commented on the incredible work in the North West Cancer Centre, which we all do applaud. But he did then mention that it was to his deep regret that he had not managed to get any traction similarly in the southern sector for over a decade. And I didn't think that was a great finish to the sentence, to be honest. So I think the hospital should be thriving, Alan. It should be playing a much bigger part in the elective framework. It's an asset, it's not a problem. It really should be an asset.
Yeah, I did notice when I came in, just, there was a lack of hustle and bustle about the place, and you can see when you go into one of the big hospitals in Belfast. But like yourselves, I welcomed the Minister's intervention over the summer when he directed the Trust to revisit the flawed consultation process. And And I saw the Trust's apology a number of weeks ago, and it was absolutely, it did need to happen. I know that that there has been a recent unsuccessful attempt to have a meeting with the senior team here at the Trust and yourselves. But have you had any engagement at all with the Trust yet since March, even at a lower level regarding the vision work?
I think it's very difficult to describe the relationship. You know, we've gone through a previous consultation structure where people in this area felt very badly dealt with. And I think had any of you been there, you'd have felt the same thing. You know, it is really unfortunate, the position of trust and mistrust. And again, you know, when the Trust brought out the permanent consultation on the biggest bank holiday weekend that Northern Ireland has, and when Stormont was sitting down, it is so hard for people to have confidence in decision making that's sprung across you. However, we welcomed Mr. Nesbitt's intervention. We also noted during the week that the CMO actually has offered as well to communicate at whatever level. So we will never say never, but we will not be entering into discussions that are meandering on for 5 or 10 years about the Pathfinder type, you know, the community model of care, the shift left. I can't remember the newest version of the name now. I'm sorry, I really can't.
Community model care, right?
Neighbourhood care model. That's thank you. But but if it's about the urgent response that the minister did ask for, to act urgently to rebuild confidence, that's the part that we asked questions and wanted to meet on, and we were more than willing to do that.
Well, thank you for what you do.
No,
Yeah,
thank you, Alan.
Thanks. Alan, second, Alan. Alan Robertson.
Thank you, Chair. Thank you, Helen, Karen, Jimmy. Solidarity from the good people of the North Coast who face a similar type battle to try to preserve and save their emergency general surgery. My deepest apologies for not being there today in person. There is a sense of irony me not being there today, but I'm an event tonight in the North Coast, Northwest area, and it would be too difficult and too challenging to try to make it in time. And the irony in that is that if I, as someone going to just an event, how challenging is it then for people who are in an emergency vehicle having to try to make it from Fermanagh up to Galvin?
Yeah.
But can I just ask a couple of questions, just so that I understand this better? You know, the Minister quite rightly say that he asked the Trust to act quickly. I think that's very definitive language. However, you go on to say there that for this Pathfinder project, it could be 5 to 10 years in the making. Can you just explain why so long? Because obviously the people of Fermanagh don't have 5 to 10 years. They want a decision on this as quickly as possible. So could you just explain that one so that I better understand that?
I will quickly, I think just two parts to the answer. The first is that I think the 5 to 10 years was actually put into context with the discussion that you had last week with the Minister and the departmental officials, where we heard mention of 10 to 15 years and then even 30 years about different elements of what might be the new neighbourhood model of care. That's why we identify it as something totally different. Okay, the actual statement from the Minister to act quickly to restore confidence, which we think is a very important phrase, because acting quickly is a key part of restoring confidence, and to develop a vision plan for SWA. It's a totally different piece of work from working on the neighbourhood model of care, and it should be a short, concise, quick piece of work where we can genuinely develop that vision plan for SWA that we think we can contribute to.
I think also just to mention that I think it was the non-executive chair, Mr. Frawley, who mentioned it in a letter to us that it's 5 to 10 year process.
Yep.
So it kind of makes it much less likely to save lives in Fermanagh.
Can I ask Helen, can you tell us a little more on the 10 core recommendations from RQIA? To what extent do you believe they have been implemented?
Here we go. Thanks, Alan. First of all, the first two of them, the double ED is still happening. I don't mind, there will be corrections to that, but I'll stand over that. That is the truth. The double ED is happening. It doesn't matter if it's happening to 2 people a week or 10 people a week, but it is happening, and it is actually, according to the Trust's own data, it is happening considerably more often than 2.5 times a week or 2 per week. The lack of sufficient commissioned ambulance capacity has been further depleted by that, the issue that the ambulance are now standing over, where they won't lift a patient unless there's a bed to go to. So I know that those were the first 2 considered urgent by RQIA, and the words that the RQIA team used when they were with you guys in March was that if these 2 persist, it will undoubtedly adversely affect the effectiveness of the clinical pathways and patient experience. And I think the only other one that there's too many in 10, but the other one is the elective centre. It's the fact that Requia stated we needed direct access to a consultant surgeon. That's not by phone 93 kilometres away. It's not that way.
Could I just then ask a couple of follow-up questions then, Helen, beyond that? Recommendation 3 used the word should. Yeah. And it used that twice. I know I've raised this committee in the past. How do you define the word should?
I don't. How do I describe it? As porous as anything. It's not definitive enough at all. It's really not definitive at all. If we're to have the same likelihood to survive with our postcode, I think a few of those open words should be a bit more defined, quite a bit more defined. I'm not impressed with those kind of open words either, Alan, but at the end of the day, I don't want to be falling out with anybody else.
Helen, you also, in your response there to me, you made reference to staff and consultant surgeons. Given that it was workforce issues that have brought us to here today, how does your group and you feel, the best course of action to try to recruit consultant surgeons to SWA?
Thanks, Alan. It's the recruitment of surgeons and other associated staff is a key element of our roadmap, and we do go through it in a good bit of detail. Page 17 for any geeks out there that want to take a look at it, okay? But waiting lists have been branded as a national shame by the newly installed regional elective care director. Okay, SWA should and could be playing a really significant part in challenging them down. We can have, in terms of getting consultants to come to work here, we have in the roadmap targeted incentives and working conditions can be developed to attract and retain surgeons, and this has worked elsewhere. There's no reason why it shouldn't work here. Developing a genuine region-wide integrated surgical network, as proposed in the roadmap again, will facilitate the arrival of consultant surgeons to SWA. Okay. Agreeing a comprehensive job plan for surgeons that includes significant sessional work in OMA, and this is a key part of the roadmap. OMA is closer to SWA than it is to Athnagelvin. It's got 3 day procedure units there's an awful lot of work going on in. It's our opinion that those consultants, we could have consultants based in SWA, and that the sessional work in OMA would provide a key base for the high level of activity that we need to have going on here, and that's a key part of the roadmap. Bringing appropriate specialities and volumes of elective work coming in here again will complement that. And I'd just say, most importantly, okay, and this is we do believe this, a sincere willingness and commitment across all the management levels of the Western Trust can lead to a strong consultant workforce being based here on a full-time basis.
Helen, Jimmy and Karen, good luck in your campaign.
Thank you, Alan.
Thank you.
Danny.
Thank you, Chair. A couple of the questions I was going to ask Alan has already got in front of me. Well done, Alan. This, I would agree with the other members in saying this is a fantastic build. When we arrived here, it's huge. I've worked in a lot of hospitals across Northern Ireland previously, and this really is a shining example of a fantastic, up-to-date hospital. It looked very busy to me, car park full. You know, we were taken through various wards and departments, and you know, there did seem to be a lot of activity ongoing. So it's clearly there's a lot going on, which is good.
Can I ask, sorry, this is probably bridge and also to rules. Were you allowed to wander around on your own? I don't know.
No,
right,
no.
sorry, just
we were taken through. But we have asked to see theatres and wards that that haven't been commissioned, and I think we were in a theatre. And we were shown that as well. So
super, yeah.
Thank you.
Yeah, no, a very, very high standard. Clearly, Fermanagh has a very different geography to the rest of the country. There's a lot of rurality here, so you know, there is different considerations. 2 questions. The first one just relates to the designation in the roadmap. That's, I think, it's recommendation 20, that SWA is categorised as a rural area hospital. Can you tell me where that came from and what that would mean?
We certainly can. The rural argument is one that we don't do very well in Northern Ireland generally. Okay, I know that anyone that's from Causeway and Daisy Hill will feel the same pain to a degree. We will say that it's even more significant here. Okay, it's 93 kilometres on average for the people of Fermanagh to get to Athnagelvin. Now that is a long distance, and it's just too far. So when we took a look at the hospitals, reconfiguration hospitals, creating a network for better outcomes, I think is the full text of it. When we looked at the document, it suggested classifying SWA and Daisy Hill and Causeway as what's called a general hospital. Now, we felt that didn't apply. Two quick lines from the definition of a general hospital. Okay, I can find it here. Sorry. Not available at the moment. Okay, it's 15. Yeah, no, have it here. No, have it here. Is why couldn't these 3 hospitals be area hospitals like the other hospitals, okay, just on a smaller scale? It simply says they cannot just be small area hospitals. The resources do not exist to perpetuate this. So it's a financial decision at its core, okay? Now, what's very important, okay, is that we didn't feel that SWA needed to be a full area hospital. And it shouldn't need to be a full area hospital. But what it should have is those key essential services needed within it to support full emergency surgical and medical ongoing sustainable care. So we didn't think that a general hospital was suitable, and we didn't also feel that an area hospital was suitable. So we came up with our own definition, and that's what's in the roadmap. And it's a very specific definition written in the tone of the consultation that should lead to those key emergency, surgical and acute services being based here in the hospital. So very interesting, but 28,494 people signed individual consultation responses, agreeing with us when we said that SWA should be designated with this new designation, rural area hospital, and that was 94% of the people that responded to the Department of Health consultation. So we feel there's a very strong case behind it as well.
Thank you. One of your other figures that jumped out at me when I was reading it was the 92 unused beds. What does that relate to? What is that?
The hospital has 92 uncommissioned beds. That was one of the items actually that I remember in the discussion on the 10th of May, because Neil, the Chief Exec, had mentioned that was a topic that he brings up regularly with the Department of Health. But there are 92 uncommissioned beds in SWA, and that's all I know.
Absolutely.
Okay. No problem. Thank you. Thank you, Chair.
Thanks. Dan?
Thank you, Chair. And again, like Alan, apologies, but I haven't been able to get with you today. Can I just ask, it's really a question around the building up of staff and so on. When we all heard that they were now going to use the 2 uncommissioned theatres, and I think we had high hopes that this will lead to an investment in staff and an expansion of theatre activity. But it transpires, as I understand it now, that this is simply the independent sector in Musgrave coming in with their nurses, their doctors, everyone using the theatres and going out again. Have you heard anything further about whether or not this might lead to the build-up of services, or is this just a one-off, short-term thing that has been announced?
We did welcome the announcement recently that there was, I think, 600 procedures planned as part of the rollout of the elective care framework for the current year. That was definitely good news. To our knowledge, that was a standalone piece of work, but that we know that there's conversations going on with the independent sector to agree long-term contracts, which we do have a concern about, because it's our preference that work in the theatres here be done by NHS staff, okay, and that it's free at the point of need. Now, we did welcome the work, but we understand the use of the independent sector, okay, but that needs to be coupled to those long-term NHS efforts to bolster SWA's surgical and medical capacity. It's in the elective care framework, which obviously is only a single year because you haven't got the multi-year budget agreed yet, but certainly for this single year, and there's some longer-term aspirations in it. One of them is that, and it's very important, is that there's an undertaking to build recurrent HSC capacity and to recruit staff to newly created posts to reduce the dependence on the independent sector. Now, we think that's very important. We have a concern that that mightn't be focused on appropriately, because when the independent sector come in, that might take the emphasis away from that. But we think it's something certainly that the committee should look at, ensuring that this intention in the elective care framework to build local HSC capacity to do this work is very important. And they can work alongside the independent sector until such time as they're well established. And then the key of our roadmap is local NHS staff working in local theatres, doing work for people from the entire area.
Sorry, Jimmy, can I just add to that, Diane? I'm sorry, just while we did welcome the story, it's 12 procedures a week that we're talking about, the knees and the hips. That actual group and the same surgeries have been here before. This is not new. It has recurred on many other occasions. But there was a letter in one of the local papers recently, or an article rather, I think it was Teresa Malloy, but I could be wrong, who had said that due to winter pressures, that it was likely that elective procedures would be less and from what they are actually even now, which, for our staff, for our hospital, it's each of those statements become very frightening issues. It is depleted enough, and to think it could be doing less during this winter is quite frightening. And as you said, Alan, the space downstairs, the calibre of the area, it should be bustling. It should be running. That's it.
Can I just say as well, in relation to that, Diane, in relation to the independent sector, theatre staff are very skilled personnel, and it takes time to develop those skills and consolidate their knowledge. So while the independent sector is probably a useful adjunct currently, it will take time to build those. We need to start now, and we need to make sure that this is that element of security. Where you have independent sectors coming in to do surgery, you will get a reluctance on potentially consultants that want to base themselves here would be reluctant to engage in that process. They want regular teams working with them. Regular teams produce good outcomes. And from the regional point of view, the job creation and sustainability and the recruitment and retention are all linked into that piece. So it is quite complex, but it's really important that we establish our own personnel delivering a high standard of care that we have done before. The one thing I think we haven't really touched on today is that We had a thriving emergency surgery department up until recently. And if you equate it to the hospital that we have here, it is most unusual that any hospital that I have seen to date with the facilities and the capabilities here have had their emergency surgery removed. So that's really important. Thank you.
Can I say thank you? I mean, I absolutely agree with you. And I know that many of you know my background. You will know that I know the SWA very well. I visited family in it many, many times. It is a fabulous facility that is hugely, hugely underused and underutilised. But if we are to build up and to utilise the facility, we can't do it without staff. And we need an investment in long-term recruitment, as you say, and we need to build up our health service capacity in relation to staff. So, I mean, I mention it because I think that the emergency surgery issue is really, really important. But for me as well, building up that cohort of staff that support emergency surgery, not just consultants, is also hugely important as well. And I do think that the announcement about the elective procedures, well, I welcome them. I mean, like yourselves, I welcome them. Anyone who's knee or hip pain will be delighted to have their surgery done. As I understand it, it's mostly day procedures that are being done. But they'll be delighted to have it done in a facility like the SWA. So yes, it is good as far as it goes. But it's very temporary and it's not an answer. And I thought maybe we were kind of being led in a way that maybe didn't help us to see the full picture. I'll maybe leave it at that in as polite a way as I can. But thank you for all that you do. I intend to pursue some of these questions with the Trust when we see them.
I just wondered, and it might be something that you could maybe bring up with the Trust. We are made aware, as I've said to you, there's a huge amount of trust placed in us at this stage by staff. There are a lot of staff who are not on full-time contracts and would love full-time contracts. There's a lot of part-time contracts. There are people who are applying for their own jobs with regularity. And there are people who we get contacting us, one even this week did, dying to get in to help out with winter pressure, but just not an option. There's not going to be. That was a nursing position, I should have said too. So it is, recruitment has to be permanent for any nurse to be able to settle in an area. It has to be completely permanent.
Thank you. Linda?
Thank you, Chair, and thank you to all three of you for your presentation. It's more than a question, it's more of a point, Chair, rather than a question. And to yourself, I would like to see the statistics around that last point that Helen made around the permanent contracts for staff, because that is true. There's absolutely no way that staff are going to stay somewhere that they're not secure, that they don't have a secured post, and that will lead to, as we said, it's actually that is what will lead to the winding down of services within the hospital. I also think that we need to get some statistics around, precise statistics around what is going on in the hospital. I would like to understand why the elective surgery would be being stepped down over the winter pressure months. I mean, I think it's probably down to the availability of surgeons, but I think we need to know that. And is it because the SWA has been used more for patients who just need to be hospitalised, who are very ill? So we need to understand all of that. I think that it's really important that we get information around that.
It's not a question.
Sorry, just the last thing that I just wanted to ask is, and I don't know if it's for us to ask the Minister, is around the commissioning of those 92 beds that Helen referred to. So if there's 92 beds uncommissioned, is that down to the Trust or is it down to SPPG? We need to understand, have bids been put in for those beds to be commissioned for a specific reason, and those have been turned down? Because I would be very concerned if I thought that we talk constantly about having services in all of the hospitals and needing every single hospital, but where there's a hospital with beds available, we're thinking it's way out in Fermanagh, not going to use that. If that's the approach from the department officials, I would be very, very concerned about that, because that's a bigger issue than the trust.
Yeah. Can I just say, just very, very quickly on that, Linda, and thank you very much, that from the point of view of when we met with the department and with the Western Trust on the 10th of March, Neil Guckian, the Chief Executive of the Western Trust, did point out, and Helen has said it already, that he's repeatedly asking the department to free up these beds, that they need to be commissioned. Okay, so now, obviously it's a question that you can ask the Chief Executive yourself, but it would seem that we should be focused on the SPPG with regard to trying to get those beds commissioned
and staffed.
Yeah, I think we need to. I think we need to
Yep.
write to the department on that one.
Yep. Yep.
Chair.
Okay.
Thank you for that, Jim. Appreciate it.
Okay.
Thank you.
Thanks, Linda. Thank you very much. That's been very useful, and we appreciate you giving up your afternoon to come before us and take our questions.
Thank you.
Thanks very much, folks.
We'd just like to close by saying thank you again. We know that it's a long way to come down, and there's been a couple of mentions of distance, okay? And our campaign is not just about distance, but it's also about the opportunity that's in SWA, and having walked around it,
Absolutely.
we trust that you'll have a much deeper understanding of that now.
Can I also say
And thank you very
that
much.
if there are further questions that are going to be asked about any of the material we've referenced, we can happily share that with you.
Thank you very much.
Thank you.
Thanks, everybody. Thank you.
Appreciate that. Thank you.
Safe trip home.
I'll not be grumpy.
Okay, members, we're just going to move on then to item number 6 on our agenda.